and thank you. I'm Numan from Ankara, Hacettepe University. I am a physical therapist, also SLP. I am working about pediatric population, pediatric dysphagia, also adult, but generally I work with pediatric population. I would like to thank you for organizing committee and Nestle to give present and give information, new tools, new screening tools, PEDI EAT. Okay. As we know, swallowing is very essential function to sustainable for healthy, and because of that, for children and for us, very sustainable. Okay, swallowing is a pressure system. We know they consist of oral cavity, pharynx, upper esophageal sphincter, body of esophagus, and lower esophageal sphincter and stomach. This system works as a pressure system to transport food, drinks from mouth to the stomach and prevent its reflux into the esophagus. Okay. We know difficulties in phases of swallowing, dysphagia. New terminology is deglutition disorders. We know dysphagia can be seen in infancy and older age. The prevalence of pediatric dysphagia increasing due to improved survival rates of children with prematurity, with low birth weight, and with medical complex conditions. Dysphagia is common amongst children with neurologic impairments, with reports in excess 19% for different levels of different severity of levels. Dysphagia, a related complication under nutrition, dehydration, recurrent anemia, weakened immune system, prolonged and frequent hospitalization, and increased risk of morbidity and mortality. And also the quality of life decreased for pediatrics and their caregivers or their parents. Okay. Right. Due to all these complications, it's important to define dysphagia and plan appropriate management plan in early period. Besides our clinical experience, SPEGAN WG group also suggests that dysphagia management plan should be performed as a clinical decision-making process. Okay. This process is a step-by-step approach which starts with evaluation of swallowing system to detect the dysphagia and proceed to next steps. Okay. You can see our evaluation algorithm, our center, which is Hacettepe University Swallowing Disorders Research and Application Center. Pediatric patients who suffer from these symptoms, including coughing, choking during swallow or before or after, wheezing and sputum, food stuck in throat, food stuck sensation in chest, regurgitation, noisy or wet vocal quality, inability to gain weight, and recurrent anemia, are at risk for dysphagia, and refer to swallowing evaluation process. In the first step, you can see that we have screening tools. The patients who comes to our clinic with the complaints I have just mentioned is taken for instrumental evaluation if necessary after observation, history, and screening test and clinical test. When we identify at risk of aspiration, we use instrumental assessment such as video fluoroscopy and FEES to determine diet level and rehabilitation technique. Screening tools are used to indicate the need for further evaluations. Thus, screening is really important for this step-by-step evaluation algorithm. And there was a big gap in here for pediatric evaluation to detect children at high risk of aspiration and penetration. Yes. What is the rationale? This is our main rationale of the idea, creating the pediatric version of EAT-10. When we look at the literature, there are several non-instrumental instruments to evaluate swallowing and feeding function in the pediatric population. The presence of absence and frequency of challenges related to eating and feeding and oral motor evaluation. And we search and we don't find any dysphagia specific outcome measurements in literature that can detect children at high risk of penetration and aspiration. Because of that, we need a clinical, we need a valid instrument to reliably establish the risk of penetration and aspiration. Okay. Yeah, as we know, the 10-item eating assessment tool was developed for adults due to the same reason in 2008. You show too many sites they took. It's the most frequently used screening tool in the clinical settings. You can see the citation numbers, which also show us its frequently used the research. Therefore, having a parent-reported tool that has a similar ability to detect penetration and aspiration risk in children will help identify pediatric patients at risk dysphagia-associated complications. Okay. We performed at the study Hacettepe University with cooperation Physiotherapy and Rehabilitation Department, Swallowing and Research and Application Center, and the Department of Otolaryngology, Head and Neck Surgery from University of California, Davis, with creator Ethan Peter Belowski. This study consists of two separate phases. One is item generation, content validity, and normative data generation. Phase 2 is reliability and validity study. For item generation, the validated items from the EAT-10 were used to generate the items of the PEDI EAT-10 during adapting the items of EAT-10 to the PEDI EAT-10. We did a comprehensive pediatric dysphagia literature review, and we take expert opinions whether items are appropriate for the pediatric populations. And in our study, 51 health children from daycare centers aged between 18 months and 18 years, with no parental report or any medical conditions. The inclusion criteria were children between 18 months and 18 years of age, referred due to parent concerns about their child's swallowing function who have been previously evaluated swallowing center. Swallowing function was imaged and recorded with video fluoroscopy swallowing study with full resolution and 30 frames per second in lateral plane. The 3 trials of 3 milliliter thin liquid and pudding consistency were used, and worst scores was considered for calculation. And we used for swallowing, we used the penetration aspiration score to assess penetration and aspiration level for children. Internal consistency was determined calculating by Cronbach alpha, interclass correlation coefficient with 95% confidence intervals was calculated to assess test reliability. Criterion-based validity was assessed, Spearman correlation coefficient to look at the correlation between PEDI EAT and the scores of the penetration pass score. The Mann-Whitney test was used to compare PEDI EAT scores between the CP and healthy children. Okay. Only one item was excluded, the PEDI, which is swallowing pills takes extra effort, and we put other item, my child takes during swallowing, with expert consensus. The final PEDI EAT has 10 questions arranged in 5-point ordinal scale, 0 to 4, as you can see. Okay. The retest reliability was excellent according to ICC scores, ranges between ICC scores, which is indicating the PEDI EAT is a consistent scale for determining risk of dysphagia, risk of penetration and aspiration in children. But we know abnormal swallowing refers a wide range of spectrum. Therefore, in the second study of PEDI EAT, we investigated the discriminant ability of the PEDI EAT to detect aspiration in children with neurological impairments. In this study, according to the ROC curve, a cut value of 13 from the PEDI EAT correctly identified 77% of children with airway aspiration. And children with a PEDI EAT above 12 were 1.97 times more likely to aspirate. And we search other survey or other questionnaire, other tools which assessing dysphagia in pediatric population. When we look at their general characteristics, they evaluate problems such as feeding and eating problems, behavioral problems, reading difficulties, and family interactions. You can see most used instruments about your child's eating, pediatric assessment scale for severe feeding problems, stepchild, and PEDI EAT were created using their other tools. Also, pediatric eating, pediatric behavioral pediatrics feeding assessment scale, and Montreal Children's Hospital feeding scale have cutoff scores like E10, but they don't predict aspiration. It classifies the severity of disorders as normal or abnormal. Till now, okay, to date, PEDI EAT is translated to different languages, Arabic and Spanish, and they invest and now ready for prepare, I think, Greek version, and I think Dutch version and French version and others, I don't remember now, too many language version will be prepared now. This PEDI EAT translation and validity studies is continue. At the end, I would like to introduce you a digital version of PEDI EAT according to our collaboration with Nestle Health Science. The digital version of EAT allows us to rapidly get the results and its interpretation, and you can scan and reach from whatever you want, wherever you want. I thank to Nestle Health Science again for their awareness and their efforts to spread to use PEDI EAT. Also, thank you joining and listening to me. Thank you so much.